Hi, I'm Dr. Henry Black. I'm a clinical professor of internal medicine at the New York University School of Medicine and a member of the Center for Cardiovascular Disease Prevention at our institution. I'm also president of the American Society of Hypertension. I want to talk today about a new way to analyze data, which is cost effectiveness, and to see if we can get some handle on what's going on around us. We have many different treatments these days to decide what to do, and we're at a time in our evolution of medical therapy where we have to ask, not only does something work, but how much does it cost? Is it worth the cost? Well, in order to do this, we don't really have, for the most part, a clinical trial to depend on. Clinical trial volunteers don't necessarily represent everybody around us. There are exclusions, inclusions that are very different from what we actually do. And even if we have a gigantic database of clinical trial information, it may not answer everything that we need to have answered. In order to do this, some very elegant and impressive statistical modeling has been done to try to understand what's cost effective and what isn't, and how this balances out. Part of this has to do with appreciation of a quality adjusted life year. That is, after you take into account whether a particular treatment is going to extend life. It isn't just that you'll live longer. No one wants to spend 6 months on a respirator in an ICU comatose, but whether you get a quality adjusted life year. And this is called cost utility, and this is something that health outcomes researchers are been doing in a very extensive and very elegant way. Well, one of the things that the group led by Lee Goldman that has looked at this of late is the issue of statin therapy and whether or not statin therapy is appropriate. Looking again at the ATP III recommendations, that is 2 risk factors, high-risk people for secondary prevention or 2 risk factors for primary prevention, or whether or not you could say, let's just take the risk, judged to some degree in our case by the Framingham Heart Study, which estimates short-term risk, and they're beginning to estimate lifetime risk now to see what's the better way. Well, this group did this in a very extensive and elegant statistical modeling. Part of the answer to this has to do with how much we as a society are willing to pay for a quality adjusted life year. How much? Is it $100,000? Is it $50,000? Is it nothing? These are questions that we have to answer. Well, they went through this very elegant description, which was recently published in the Annals of Internal Medicine, estimating the costs of what they called high-intensity statins, which cost on average somewhat less than $3 a pill, and low-intensity statins, which cost more like $2.10 a pill. And these are estimates that are not necessarily accurate because the cost of a pill depends on a whole variety of other things in addition to what the charges might be. Then they looked at this based on what the estimated risk was, what the ATP III recommendations were, and once again estimating how much this would be. It turns out that AT3P recommendations, it would be reasonable to have either statin because it costs less than $50,000 per year for a quality adjusted life year. And that seems to be about the benchmark. They did something called Monte Carlo simulations, where they take a whole variety of different outcomes. They used 1,000 per this to get a sense of where this fell. And using the ATP III recommendations and statin therapy with either high intensity or low intensity therapy, all of it seemed to be less than $50,000 per quality adjusted life year, and all less than $100,000 for sure, even with the more expensive of the 2 classes of drugs. Very similar to what was found in England using similar results. Now, what is also clear is that this is very sensitive to the price of statins. And as the cost of statins is reduced from more than $2 to $1.50, down to 67 cents, down to even less than 20 cents, it becomes more and more cost effective. And in fact, at the cheapest price, it would be reasonable to treat everyone over the age of 45 up to about 79 with a statin to prevent outcomes. we would save 20,000 MIs and 10,000 episodes of heart failure. They didn't look at strokes, which is interesting since statins also probably prevent strokes. So this is very cost effective. And one of the things we're going to have to do is look forward to better estimates of risk to see if risk estimates better, new ATP adult treatment panel recommendations, which are imminent, to see whether or not we ought to be recommending statins for even low-risk individuals. Everybody would rather not have a heart attack, but if the society is going to take on the cost, we've got to be sure what we're doing is cost effective. It's interesting, too, that the same group took all HAT data, a very large clinical trial, 3 different classes of drugs were compared, and their findings were a little bit different. Turns out that the most cost-effective drug, or seemingly most cost-effective drug at $50,000 per quality-adjusted life year, seemed to be a calcium channel blocker, amlodipine, rather than chlorthalidone, which was the cheapest per purchase cost. They were hesitant to go forward with these recommendations because even if a study that large, they felt it was underpowered to really tell the difference. There was a little survival benefit, about 0.37 years with the calcium channel blocker, but that was clearly more expensive than the diuretic chlorthalidone. Now that amlodipine is generic, that may be a very different estimate. So pay attention now, because this is something that members of the government have received money to try to do. We as physicians have to be sure that we agree with what they say. Thank you very much.